Bismillahirrahmanirrahim. On the behalf of President, Pakistan Society of Haematology, General Pervez Ahmad Hilal Imtiaz Military, I welcome you all to this third webinar organized by PSH. This time we have selected the topic of acute myeloid leukemia, and we have invited experts from all over the globe. And we are very thankful to Brigadier Altaf Chaudhry, Brigadier Kamran Mahmood, and Dr. Saif from Doha, Qatar, that they have spared their precious time for this webinar. We have updated the Zoom application for more than 500 participants now. Previously, only 100 participants could join in, and there were many requests. So this time we have updated the package and 500 participants can join in. So for welcome note, I would hand over to President, Major Pervez Ahmed. Over to Sir Pervez.
Thank you, Marine. As we all know that PSH is trying to promote the academic activities in the form of regular series of webinars. And we are trying to promote the hematology knowledge and practice among the physicians, hematologists, oncologists. And one of such area is acute myeloid leukemia that we know is a complex topic, and it's very difficult to have a hold on the precise diagnosis, monitoring, and management. And we are fortunate to have expert speakers who have got vast experience and knowledge on acute myeloid leukemia, and they'll be putting us wise and enlighten us on all the aspects of acute myeloid leukemia. We will start with the Brigadier Chaudhry Altaf Hussain, who has been HOD Hematology at Armed Forces Institute of Pathology, and this would be followed by Dr. Saif, who though young, but he is vastly experienced and was HOD BMT program at Manchester Royal Infirmary before joining this center, cancer center at Doha. And then we have got Brigadier Kamran Mahmood, who is a transplant physician and has been dealing with acute myeloid leukemia along with the transplant for over a decade now, and will hand over the organization to Dr. Marine.
Thank you very much. So our first talk is very, very important for the resident. That is an integrated approach to the diagnosis of acute myeloid leukemia. So your exact treatment, targeted treatment, depends upon the right diagnosis, So for this, we have invited our teacher, friend, colleague, and a very expert morphologist, Brigadier Chaudhry Altaf, retired from FIB, and now he's principal of CMH Institute of Medical Sciences at Bhahawalpur. So thank you very much for sparing your time. And I hope your talk would make the residents more wiser, and even us. We are anxiously waiting for your expert talk. Thank you very much, sir.
I'm very thankful to President PSH and of course Dr. Marine. She's always using the words which even we don't deserve. But thank you very much, Marine, for your very gracious comments there. Although I'm away from the practical work for the last few years, but the love for hematology is still there. And once I was asked to talk about this acute myeloid leukemia, I was a little bit perplexed. Should I start it or not? But I would just again say thank you to General Pervez, and I would try to cover this topic, which is a very huge topic. I remember that my first interest in acute myeloid leukemia started in '95. I was told this that I have to work on this high dose RSC in AML. That was a breakthrough in '96. Since then, I am working, reading, studying this AML. But as we study, as we go ahead, it becomes more and more complex. So, this limited time of 30 minutes, I would just try to give my experience and gives importance why we need an integrated approach, and plus another task which General Sahab told me that I should tell them how we can work in countries like Pakistan, which are resource constraints. So this is the place right now where I am working. This is my institute. It looks very green, although once we talk about Bhahawalpur, It gives the impression of that we are staying in desert. But it's a very green area, and this is a place where I am right now sitting and delivering this lecture. But inshallah, in next year and so, this is our future of our college, and we'll be shifting to this building, which we have just, I think, I worked over the last 1.5 years to get it approved. Now it is under construction. Now coming to topic. As we know, this AML is a malignant disorder. It has few words in this definition, which are very important to understand. One is the malignancy. Second is a complex. This complex word is not by me. It is mentioned in every book. So when many senior people say it's a complex, that means it's a very complex disorder. And we need a lot of understanding to understand it. And secondly, it is not a disorder of one cell. This disorder is because of cells of variable with differentiation. But although they are myeloid cells, but they have variable differentiation. So this all makes this thing very complex and heterogeneous. So the basic responsibility of a morphologist or a hematologist or a team of hematologists is to give a diagnosis, which is very integrated, which is very precise, and it goes to the ultimate type, which can help the patient management strategy. And I'm very sort of depressed to say that though in the last 25 years, the only thing which has improved about survival, that initially we used to talk about 3 years survival, about 25%. In just last 25 years, we just can say that it is 5 years survival about 25%. So it's still a challenge for hematologists who need to work more on that. And then coming to the etiology, we know it's mostly unknown, but there are certain risk factors like advancing age, male sex, smoking, exposure to chemicals in the form of benzene, formaldehyde, then pre-existing MDS, MPNs, and then of course a very favorite Fanconi anemia and Bloom syndrome. All these conditions, they predispose a patient to develop AML. And then this, I just told about that why we need a precise diagnosis, because our job is not only to label as AML, but to exactly identify its subtypes. And then we should be able to give patients data that will help to us to stratify whether it is a poor risk patient, whether it is a good risk patient, and what treatment strategy they can work for the patients. So these all are the mandates of a morphologist or hematologist who is giving out a report. So coming to this classifications, I will not go to details. All of us knows that we started with FAB classification, but right now we work with WHO classifications, and this started in the year 2001. And every year they are putting more and more information in this classification. And I will start with one thing, that right now the criteria has been reduced from 30% blast to 20% blast in the bone marrow or blood. That's the first criteria to label somebody as having acute myeloid leukemia. And if you ask me why 20%, I will not be able to answer this question. It is open for everyone to discuss this 20% criteria by WHO. Later on, WHO said, no, even there are patients, even they don't have 20% blast, still we can call them AML if they have certain translocations, like in the form of 821, inversion 16, and translocation 1517. For these translocations, if present in a patient, even we don't need the criteria of 20% blast cells, and we can label patient as having AML. Similarly, this list is ever increasing, and this is a list of many mutations which are right now provisional entities. But as we gather data, maybe after a few years, we have many more entities in this second group of this translocations. Maybe there are more conditions as we gather data that is confirmed by scientific studies. So these blast percentage figures may not be relevant in these conditions. And then there's a need to do molecular profiling because this is mostly done either by face studies or by RT-PCRs. It's a long list of tests which are ever increasing. And the main aim is because European Leukemia Network, they have to decide, they have to stratify the patient into prognosis, whether they are from belong to poor group or intermediate or favorable. And just one thing, I will not go in details of all these abnormalities. They are written in books. But one thing, please remember, we just studied 2 or 3 these abnormalities in our setup, and the things which are good and maybe in Western studies, may not be very relevant to our own setup. So we have to study our own population as regard the treatment is concerned, whether they are still good, which is good for European countries, maybe they are not good for us. Because our experience with this FLIT ITD is not something which really described in literature, though our data is very limited. But these things, the important lesson is, we must know all these abnormalities, but please, once we apply to our own population, it may not be same as has been written by European Leukemia Network. And then coming to this WHO classification, it has divided this whole AML into 6 subgroups. First is, of course, acute myeloid leukemia with recurrent genetic abnormalities. We'll discuss about it. Then AML with MDS changes. And then is therapy-related AML. Then is the AML which is not otherwise specified, AML NOS. Then is the myeloid proliferation, which is seen in Down syndrome. And then, of course, once we see this neoplasm of AML outside bone marrow and peripheral blood, that is called as the myeloid sarcomas. But to work on these, we don't have one thing. There are a long list of things like history of the patient, morphology of the blast, identification of the blast, then their counting. Then even we have to work on the non-blast morphology. Dysplasia, again, is a lot of thick fog on this dysplasia. And then is the important thing is, we are jumping toward the cytogenetic studies, to the FISH studies, to RT-PCRs, to sequencing, to NGS. But important, as we are moving toward this latest techniques, the fear which I have got, and I have seen it many times, we are forgetting morphology. Please remember it. Morphology plays a central role in this whole diagnosis. You may get any mutations, but if it is not fitting your morphology, you have to rethink about it. And unfortunately, as we are getting more and more trained hematologists, our experience in morphology is going down and down. I think which is a point of concern for whole PSH. I think that there's a need to work on, work on getting the required expertise in morphology. Unfortunately, in the youngster lot, there is more of the knowledge of mutations. They believe more in mutations. याद रखिए, mutation हरफ़े आखिर नहीं है इसमें. I have seen many cases where we have to even look back towards the mutation analysis, because these are new techniques. कोई भी टेक्निक आती है जब किसी जगह पे, it takes years to develop it. It takes years to understand कि इसमें क्या खराबियाँ हैं. ब्लाइंडली आप अडॉप्ट करने से एक एनजीएस आ गया है, आपने लगा दिया है, सीक्वेंसिंग आ गई है, कर ली है, तो इंस्ट्रूमेंट तो आ जाता है, बट टू गेट दैट फंक्शनिंग, वो जो एक्सपीरियंस ट्रेन मैन पावर है, that takes decades to develop before we can rely it fully. So there's a lot about these new techniques. We should adopt them. We should work on that. But please remember it. My experience is that it should always revolve around morphology, unless there is something very gross in these molecular profiling. This is a very important lesson which I wanted to give. So this is what is the requirement. It is basically integration of morphology, cytochemistry, immunophenotyping, and then cytogenetic studies by conventional techniques, by FISH techniques, and by RT-PCRs, and by sequencing. All these have to integrate, and there are areas where they play an important role. Now, coming to material, what material we require to work on AML patients? Of course, if you look on this table, this is the targets of studies. Targets are 4. First is diagnose AML, then is to subtype it, then is to define some sort of prognosis if possible with your means, and then to identify treatment targets. These 4 purposes should be kept in mind while we are working on a case of acute myeloid leukemia. And the material we use is best is bone marrow aspirate for morphology, and you look at this morphology help to define AML and to subtype. This morphology doesn't play any role in prognosis and to identify treatment targets. Similarly, next is flow cytometry or by immunohistochemistry. Flow is usually done on bone marrow aspirate, and this refined biopsy is used for immunohistochemistry. Again, look at this limitation. This may be surprising to most of us. It's only just help to diagnose. just to define lineage. It is AML or ALL, just by leukemia. It is still unable to define subtypes, to define prognosis. Maybe we have data in coming days, but till date, it's only helped to diagnose it is AML or not. So this is the value of flow cytometry, which we are starting believing so much. I will have a little bit stress on this flow cytometry in the last slides of my lecture. But please remember this, it's only helpful in defining lineage, and that too if it goes with morphology. Coming to the cytogenetics and mutational assays, yes, they are important because they cover almost all the 4 aspects, but these should be very judiciously used and interpreted because our experience in these techniques is a little bit limited. We had a short experience, and any technique which is we are using, we must spend at least many years before we can rely on it completely. Now, coming to history, yes, every one of us knows is the role of history, especially in this AML, like if there's history of MDS, we label it as AML MRC. If the history of exposure to radiation and drugs, we call it therapy-related AML. And if there's a family history of platelet disorders, mostly these are the patients which have germline mutations. Similarly, family history of hematologic disorders that again have a little bit this neoplasm with germline mutations like GATA2. And then history of mediastinal germ cell tumors that suggests that this patient may develop AML-M7. And similarly, if patient has a features of Down syndrome, normally they have either this AML-M7 or even the transient proliferation of myeloid cells which are related to Down syndrome. So this is the value of history in AML. Now, clinical features, peripherals, yeah, I just discussed before, it's the same thing. Okay. Now, because this topic is too wide, I just wanted to share my experience of AML and this lesson we learned from this journey of diagnosing over 1800 cases of AML. From year 2008 till 17, we almost were diagnosing around 180 cases per year, and mostly they were adult, and 1/3 were pediatric AMLs. And this is the distribution of these cases, which we diagnosed in over almost 10 years. And look at the FAB classification. Most of the patients belong to M1, M2, and 3. And basically, in adult group, the most common was this AML M1, whereas in pediatric group, it was basically AML M2. But look at one thing, this AML M0. It is mostly seen in pediatric populations. And similarly, unfortunately, we couldn't even a single case of AML M5 in pediatric age groups. This is maybe astonishing. We have something, we're unable to diagnose it, or we are not having any case. But this is something very astonishing even for me, that we didn't have a single case of AML M5 in pediatric age group. Now, this process of diagnosing these around 1800 cases, we learned many lessons, And I will just highlight few lessons which I think are worth this forum. And I've just used my own words for like this rough ride. I labeled those cases as rough ride, where even after spending months of times, even patient visiting 2 or 3 or 4 centers in Pakistan, he was not even able to get a diagnosis of acute leukemia. What to talk of AML and then further subtype, whether it's not, whether it is therapy related, because only even we couldn't label him as a case of acute leukemia. I'm not talking about myself only, FIP only. I'm talking about a very developed parts of Pakistan. So these are the cases I usually call them as this was our rough ride toward diagnosis. And then, fortunately, there were cases which, if you just label them, just talk about them, they sound very rare cases. They sound that how you have diagnosed it, but they were very easily diagnosed. And I call them as a smooth ride toward diagnosis. I will have one case from each group I will share with the forum. Then we learned many things, how to develop infrastructure, how to work with the the cost involved. This is our poor population. The cost on fish studies, the cost on molecular profiling, it is ever increasing. How to reduce for the patients? That is something which we as hematologists, as PSH, should devise, because everyone cannot afford all this cost of these new tests. We have to work on, because they are necessary. Importance nobody is denying, but the cost being afforded by patient, by poor patient, that should be a consideration. And the final lesson which we learned, that we were working in isolation, like immunology and like hematology, and there were many complaints about diagnosis. At times, we were wrong as morphologists. Many a times, the flow finding were different. And then, under the guidance of our President, General Parvez Ahmed, we started having integration reports. And initially, it was difficult. It's not easy to convince some department, please come and see and sit with us. But we pursued it, we convinced them, and believe me, once we started working together as a team, the results were astonishing. And the number of complaints, they reduced. And even those departments who were initially unwilling to sit with us, they said कि जी बहुत अच्छा कर रहे हैं आप, हमारा बड़ा फायदा हो रहा है. It's a mutual learning also. So this was the lesson, and the final lesson we learned, that we must integrate our services with immunohistochemistry, antigen biopsy, and our flow cytometry study from immunology department. And that is I think, is out of all these lessons, is the best lesson we have learned. And I will stress rather to my colleagues in this forum, please try to adopt it, because I knew it. There are many centers who are working in isolation. एक जगह से bone marrow होती है, एक और जगह से flow होती है. I'm talking about big cities. Flow में कुछ और होता है, flow में AML है, pathology पे ALL है. Such are differences. So we should try to integrate these reports, and we should put an effort to send a patient to a place where these studies are available under one roof. So this is one important lesson we must keep in mind, and I will request my junior colleagues to follow it, please. Just for coming to a rough right toward diagnosis. This was a child of 2.5 years from Multan. He had a history of bruises. For about 1.5 months, he went to his physician and he was advised by CBC, which show a low platelet count. He was diagnosed at a division headquarters, not a small city. He was diagnosed as a case of ITP and started with steroids. It's a very common practice. Many of you may be having such cases in your experience, but this is something more complicated than the simple diagnosis of ITP. He was started with steroids. He didn't have a response. So parents, they were folding. They took the child to Lahore. And after 1 month of this initial diagnosis, people at Lahore, they performed bone marrow examinations. And they gave opinion of that this child is not having IDP. In fact, he is having hypoplastic ALL, which is very common in children. I know about 1/3 of leukemia and children are hypoplastic. So that was the diagnosis. But unfortunately, no further workup was done there. Especially about I'm talking about flow cytometry findings. And patient for treatment purpose, because the hospital which did the bone marrow, they were not offering treatment. Our patient was not satisfied. He looked for another hospital, which I labeled as a hospital 2 at Lahore. And they went there. And unfortunately, hospital 2, keeping the reputation of hospital 1 in mind, they just believed the report, and they started induction therapy, or it may be a business. I cannot say anything. But again, that something happened. They just started induction therapy on that patient. And they did ask the patient to bring back the slides. Induction started after 1 or 2 days. The slides came. They were maybe reviewed after another 1 day. And after a few days, once they reviewed the morphology, they said, no, this is not ALL. This is aplastic anemia. So they stopped the chemotherapy, and they started the planning of treating the aplastic anemia. And for aplastic anemia, in severe cases, all of us know that the bone marrow transplant is the best option. They started working on it, and they looked for the siblings. Unfortunately, no sibling was actually matched. So they thought of a haploidentical transplant. Meanwhile, patient, little bit, somebody told him to go to Rawalpindi. So from Multan, he went to Lahore. From Lahore, visiting two hospitals, he came to Rawalpindi, where slides were examined, and somebody said, no, should have a repeat bone marrow. And these are the accounts of a repeat. After about 2 months of initial diagnosis of ITP, and they showed a pancytopenia. Platelet was 17,000, HB7, ANC is 440. With these findings, the bone marrow was done, which showed hypoplastic. They were around 10% blast in the bone marrow, which was, of course, hypoplastic. And this was a refined, very markedly hypocellular refined biopsy. So he was labeled as a partially treated case of ALL. Maybe right or wrong, I cannot comment, but he was labeled as a partially treated ALL. And he was advised to have another bone marrow after 4 to 6 weeks. Now, meanwhile, patient, because he had been advised as a haploidentical transplant, he approached through some resources at Glasgow and for this haploidentical transplant, and they advised one thing. They asked, please clarify your diagnosis, and that is something I call rough ride. After 3 months of wandering around in whole Pakistan, another center in part of Pakistan, in UK, that is telling him, please clarify your diagnosis. Meaning why we were unable to diagnose this patient after 3 months. And he visited every center. Even I haven't omitted few centers in this slide because time was limited. Even he went to Karachi also. But we couldn't identify what is his diagnosis after 3 months. So it was repeat bone marrow again showing a hypoplastic marrow. So the final diagnosis after repeat was that he has got a marrow hypoplasia. That is the only thing we can give him after about 3 to 4 months. You have got hypoplasia of marrow, which could be iatrogenic because of treatment you have received, or it because of ALL, because they were lost about 10% initial bone marrow. So this was what we could offer him after 4 months of visiting the patient in different centers in Pakistan. And reasons I will not go, all of us know this. First was somebody must have missed blast at the Multan, then the workup at Lahore was not complete, and workup was at not in the integrated approach, somebody working in some center, some another center, and they were working in isolations. These are the pitfalls. I will not go into details. Now coming to smooth rides. This is one extreme. Coming to another extreme. This is a very rare case I am going to discuss, but just work out how smoothly it was diagnosed. He was again a child, male child, 3-year age, and he had a history of fever and bruising, the typical history of acute leukemia. Then he had a visceromegaly, spleen was enlarged, liver was enlarged, his platelet count was around 10,000, he has this thrombocytopenia. So bone marrow was advised, and bone marrow showed us blast. These are the blast with very rounded nuclei, with prominent nucleoli, and then look at this strong basophilia, and please pseudoparts. All of us who have a good morphology, we know it. This is a picture we usually see in AML M7. These are the megakaryoblast we see. So if we just had a patient with the history of acute leukemia, blast showing morphology of AML M7, we advise flow cytometry, and flow again showed a very strong expression of CD45 and 34, suggesting this is acute leukemia. Then about CD41, CD42, and 61, these are the markers of AML7. So we were able to label him AML7, I think, within 2 days. And then we said, okay, let's talk about karyotyping, because AML7 basically it is mostly either related with Down syndrome or is because of non-Down syndrome. So just to differentiate between Down syndrome and non-Down syndrome, we have to do a karyotyping. However, the clinical examination did not show any sign of Down syndrome, and fortunately, even cytogenetics did not suggest anything. There was no trisomy 18, and we very smoothly label him as a case of non-Down syndrome AML7. This was just a result of a teamwork, working together. diagnosing a rare thing with very ease. So if we work in the form of team, if we work in the form of integration, we can diagnose rare cases in very limited time. This is one lesson we learned over our experience of these 10 years. Now, just coming about experience about karyotyping and fish results, out of all these cases, we performed these studies on only 150 patients. And look at it. This is very disheartening karta hai. Only in 20% patients we had some finding. Otherwise, mostly cases. And this is not a story of me. I believe if we talk about, if we just analyze, अपन audit करें अगर तो हमारा सबका ओवर पाकिस्तान में इससे अच्छा हाल नहीं है. If we talk about the results of these genetic abnormalities, the detection rate is not very high. We are very sort of इसमें बहुत पीछे हैं, बहुत काम करने की जरूरत है. और ये भी जो फिगर 21% की आई है, आई जस्ट एक जो इसमें इंश्योरेंस है, ये आखिरी सालों में हमने फिश ऐड कर दिया. फिश ऐड मोर सेंसिटिविटी एज कम्पेयर टू कैरियोटाइपिंग. सो ये जो अभी 21% की फिगर भी है, थैंक्स टू फिश फैसिलिटी विच डेवलप इन लास्ट 2 years, उसकी वजह से सेंसिटिविटी अराउंड 20% आ गई है. अदरवाइज जो सेंसिटिविटी है टू पिक दीज क्रोमोसोमल abnormalities or genetic abnormalities is very sort of very low than the desired level. The defects are much more common than we are diagnosing. So this is, I'm not talking about our center is very advanced or very, but we have adequate facilities with us, adequate trained manpower with us, but still we are unable to diagnose the desired number of patients on karyotyping. This is another lesson. वो कहते हैं audit बड़ा मुश्किल होता है. Audit is bitter, unfortunately. Audit is bitter, but like washing, we have to do it. इसलिए मैं कर रहा हूँ. ये जो audit है, this is not only for me, it is for all of us. ये चीजें हैं जो हमारी जो weaknesses हैं उसको identify नहीं करेंगे तो उसको improvement नहीं होती. Now coming about the positive cases which were 32, the most common defects as we expected, they were from the recurrent genetic abnormalities like translocation 15, 17, 821 and inversion 16. And mostly second group was those chromosomal defects which we see in MDS in the form of monosomies and trisomies. This is just distribution. This is a translocation. Major group was 1821 followed by 15, 17, inversion 16, and these are the monosomy and trisomy. And we have a complex karyotyping, again a feature of MDS. Now, let's talk about our experience about this molecular profiling. We did this profiling on 108 cases. And out of these cases, double negative was a major proportions. Both NPM1 and FLIT IDD, they were negative in around 54 patients. So again, I don't know, this was generally negative or we were unable to pick it. I cannot say, but these are our experience. It is open for discussion for everyone, for your comments, inputs. Then dysplasia. I'm very astonished. We are very sort of having a habit of writing dysplasia, something very close to, I don't know why, to all pathologists and hematologists. I have to remember one quotation, which I tried to forget. I learned it in initial days of my pathology training, that dysplasia lies in the eyes of pathologists. At that time, we used to call histopathologists, but I still believe that they were not wrong. This is a study which is published from UK, the best morphologists in the world. They gave the opinion on healthy bone marrow, and they diagnosed dysplasia in a healthy bone marrow donors. So please be awareful, be careful while reporting dysplasia in these patients. This is the approach which I would just highlight. It has been written in all the books if once we're following this AML diagnosis. And the important thing is the first point where everyone should stop and everyone should have achieved this milestone is to demonstrate whether there are blasts, and these blasts should be confirmed by morphology, by cytochemistry, by flow, that they are myeloblasts and they are more than 20%. If they are less than 20%, we have a different algorithm. But if they are 20% blast, then we go toward the history of patients. And as we know it, already dusk, we just have a history of some therapy before that, history of dysplasia, and then we move toward this cytogenetic studies. And they are of two types. One is of this the form of recurrent changes, and we label them as AML with recurrent changes. The otherwise, the changes which are shown is light orange color. They are the new changes which are provisional entities, and then even you can move toward the. Okay, now coming to the material which are used, I just discussed before. Now coming to, I was told to talk about this flow cytometry. Flow cytometry, it looks very good. I've just wanted to share one slide with you people. I'm sorry, there's some slides has been missed in this. There's a slide by a very famous immunologist, and he says to his immunology colleagues, please be careful that this flow is not something very helpful to define lineage, especially when the experienced morphologist is unable to commit us lineage. So we have to be very careful while we are using this flow cytometry study to define the lineage. And the sources of error, just talking about a common error which we can have in laboratory, like mislabeling, like missing antibody, like inadequate lysis of RBCs, like inadequate washing, insufficient permeation. All these, they play a role before we can define, we can rely on the results of flow cytometry. So just a blind belief that this is flow is of AML, is of ALL, is not something which should we adopt. We must integrate it with the morphology. If it is going with morphology, it's okay. If not, please repeat both things. Have a look on morphology, a relook on morphology, have a relook on your flow cytometer markers, because there are many pitfalls. And besides these technical pitfalls, there are many more, like gating process. Gating is a very important step in flow cytometry. And if we do not have a morphological diagnosis, we either use this gating by CD34 versus side scattering or weak CD45. If we do not have this diagnosis, we'll be wasting our cost. Cost will increase. And even the pitfalls. If you have used this CD34, you may miss this AML-M4. You may miss those leukemia like M3, which are CD34 negative. And if you are using weak CD45 gate, you may falsely include cells which are normal promyelocytes, which are normal monocytes, which are myelocytes, and even non-lyse erythroid cells. And similarly, hematogones. So you have to integrate your immunoflow cytometry finding with your morphology. It will not only help in saving the cost of flow cytometry, it will reduce the panel, cost of panel, and it also will have a reliable result if we integrate both of these. Unfortunately, these are the things which are still need to be worked in our setup. This is, I think, I got this slide. This is the word by the famous immunologist. We almost take for granted the ability of flow to assign a lineage in acute leukemia and lymphoproliferative disorders. Even when the most experienced morphologist is struggling to define a disorder according to the light microscopic findings. So this is important. And secondly, the reference data. If the Department of Immunology, it combines the data which is obtained from morphology, it helps them. Unfortunately, the weak point comes here. The bone marrow is done by some resident training. He is not good in morphology. And the demand of flow cytometry is that you must write on a page what number of blasts are there in the peripheral blood or bone marrow and what is their nature. But that training, that resident, we have left to him, left to her, and he may commit some mistakes, and they may not be even good for the flow cytometry department. So that step must be taken very cautiously. Once you are sending a specimen to morphology, to flow cytometry, either we tell them, please do your own Schlichman slide and your own workup for blast. Otherwise, if they want to have a blast count from you, please make a plan, make an SOP that this is reported by your experienced morphologist, and that information goes to the flow cytometry department. And there's a chapter in this book of flow cytometry. The chapter's name is Limitations of Flow Cytometry. They are very gracious people, flow cytometry people. They have included one chapter, and this title is Limitations. And they accept it. There are many pitfalls if we don't take care of these weakness in our flow cytometry. And the only way to identify these pitfalls, these limitations, is if they combine the flow cytometric finding with the morphology. Combined report is the need of R. And coming to the last part of my slide, resource constrained countries and AML workup. I will just say three things. First of all, they say that even those countries which has unlimited resources, they cannot spend unlimited amount on healthcare. This is one lesson. And secondly, the countries which have a limited resources, they need to use the resources as per requirement, so that patients who can be treated, they are not, they should not be denied this opportunity. So this is a word by Barbara Jabin. Most of us know her, and she says that all the tests which are required for AML workup, they should be done in every patient, no matter if he or she belongs to which type of country, whether from a rich country or from a developing country or from a third world country. And this is Marine, I know I may be overshooting time, just one or more slide. This is the way we should work in our setup. If we have less money, we should outsource complex investigations to our neighboring countries, our neighboring cities, and we should develop a system to transport samples. And if we had one good center in Pakistan, most of the countries should work, get from that center, and then later stages, we can twin the center with the peripheral centers. And this is what I want to say. And thank you very much, Dr. Marine, for your time. I know I may have overshooted, and this is what I wanted to talk about AML. Thank you very much. Thank you.
Thank you very much, sir, for such an enlightening talk. Questions and answers can be taken.
Thank you.
So, ladies and gentlemen, our next speaker is Dr. Muhammad Amir Saif, who's a graduate from my own beloved institution, my great alma mater, King Edward Medical University. He is the graduate of KE, and after graduation, he completed his training in clinical hematology from UK, followed by his doctorate in stem cell therapy from University of Manchester. He worked as bone marrow transplant physician and clinical hematologist in University of Manchester Hospital for many years, and recently has moved to Qatar, Doha, where he's working at NCCCR, National Center for Cancer Care and Research. He's going to speak about a very important topic, that is minimal residual disease. It's very important for the residents as well as for all the clinical hematologists, transplant physician, and everybody in clinical hematology setup. Thank you very much, Dr. Saif, for joining. Over to Dr. Saif for his presentation.
Thank you very much, Dr. Marine and the Pakistan Society of Haematology for inviting me to do this talk. I'm sure that you will all agree that measurable residual disease, or MRD, that's what we call it these days in acute myeloid leukemia, is a fairly challenging task to accomplish in a presentation in 30 minutes, but I'll do my best. It's in contrast to MRD in other illnesses such as acute lymphoblastic leukemia, where we know what we are dealing with and we know what the meaning of MRD in those illnesses are, and we are able to do something about it. So AML is fairly challenging, and hence I would not do a very elaborate and elegant talk, but what I would do is to try and confine myself answering some very basic questions. So the questions that I'm going to try and answer in the next half an hour is what are different techniques for MRD monitoring that we can use in acute myeloid leukemia? Which MRD techniques are better? What does MRD tell us? That is a relatively easy question, but do all techniques provide us with the same information? I think that's a more challenging question to answer. And what can we do about it? And that's the real challenge of today. So I will start with a case history. It's a patient that I treated in around 2011 in 2012 in Manchester, United Kingdom. It's a classical case of a patient where there can be those difficulties in management, and there could be more than one different views from different groups and different clinicians who are treating the patient. So a 31-year-old male who is presented with acute history with leukocytosis and his peripheral blood film and flow cytometry confirmed myeloid blast. So it's a case of acute myeloid leukemia. Further workup shows that it's a case of normal cytogenetics, but there comes the problem. So he's got FLT3 ITD positive, and he's also got NPM1 as well, mutation. Now, at that time, we did not have FLT3 ITD allelic ratio available, and we were treating this patient within the MRC trial, which was AML 17. So we gave him induction chemotherapy with daunorubicin and cytarabine, and we also gave him the FLT3 treatment, which was available at that time, which is listotinib, which is CEP701. So what do we do? Where do we go from here when it comes to assessing the disease response? So how can we monitor? Now, in the previous presentation, Dr. Altaf quite elegantly kind of presented slides on various techniques. So I would not go into the technical aspects of these interventions, but what I would do is to very quickly go through the shortcomings, the pros and cons of what we do and how we can monitor these cases. So morphology, again, everywhere in the world, it's a quick and cheap method. But it's very subjective and crude. And when it comes to measuring the minimal or measurable residual disease, morphology may not be good enough. So we've known about chromosomes for nearly 200 years, but it was only in 1960 when we started doing cytogenetics as a clinical modality, but it requires evaluation of cells at a certain stage of cell cycle. It's a robust and comprehensive technique, and it's widely available, but again, it is labor intensive. So we've come across that scenarios where a patient, we've requested cytogenetic analysis and you don't get the result for another few days. So you can't wait that long these days. So you have to move on. Again, if the patient has some form of cytogenetic abnormality, only then you will be able to measure the disease with the help of cytogenetics. So we moved on to more advanced techniques like fluorescent in situ hybridization, where you're using immunofluorescent probes which stick to the abnormal DNA sequences. So it has made the process quicker. But again, you have to have cytogenetic abnormality or a target which you are which you are looking for in order to be able to evaluate the patient. Again, the sensitivity of this assay when you're looking at the deeper level of response is not that great, not very much different from cytogenetic analysis. I think it will be fair to say that flow cytometry, when once done in the form of multi-parametric flow cytometry, is an intervention where you're able to look at the deeper response. So there are two main techniques in that. You can, if you have a presentation sample, you can look for leukemia-associated immunophenotyping. So what you're looking at is you're trying to identify an immunological footprint. So it's expression of antigen on the surface of leukemia cells. And what you're looking for is an aberrant expression of those cells, so of those antigens on the cell surface. So in other words, what looks like normal is not your target. What is abnormal there is what you identify as a blast population, and then you follow that up. However, if you don't have a presenting sample, you can still do what is called DFN, or different from normal. So you know what should be manifested on the surface of leukemia cells. So you if there is an aberration within that pattern, that you know that this is the blast population. Now, the biggest advantage of this technique is that you are able to identify aberrant pattern in majority of cases of acute myeloid leukemia, nearly 90%. And also it excludes apoptotic cells. So whatever measurable residual disease or MRD you're able to identify are the viable leukemic cell clone. So that is also a very useful piece of information. However, there are some disadvantages, and I think Dr. Altaf really very elegantly described how the difficulty in gating strategy and expertise of the investigator can alter the results. So you have to be very, very careful. So these assays are very difficult to standardize. ELN MRD working party has come up with some suggestion as to what you should use as early markers or myeloid or monocytic markers. And then when those markers are coupled with differentiation marker, or when you're able to identify that aberrant antigen, then you know that you've got your population of interest. Ideally, you should use 8-color multiparametric flow cytometry with at least 500,000 to 1 million event for MRD by MPFS to FC to be meaningful. Polymerase chain reaction is also now a technique that has been in use for a long time, and we have plenty of experience of using PCR these days. So it relies on amplification of DNA or RNA, but you need to have potential target. So in other words, you need to know what you're looking for. So the target could be fusion transcript, or it could be mutation or overexpressed gene. The advantage of this technique is that it is much easier to standardize. Again, it will require technological development. You will need to have machines, equipment, human resources, and so on and so forth. But it's a highly sensitive method of not only detecting, but also quantifying a minimal MRD. The disadvantage of this technique, even though, is that you're again looking at a target. So if you don't have that mutation, then you're not able to have MRD in those cases. And it's only about 30 to 45% where you're able to identify a target. Now, that is where the MRD differs in acute myeloid leukemia compared to acute lymphoblastic leukemia, because as you know, that lymphoid cells are frequently associated with receptor rearrangements, and hence you're able to identify based on PCR in majority of cases of ALL some kind of marker that you can use for MRD assessment, unlike acute myeloid leukemia where that's not as straightforward. There are newer techniques like digital droplet PCR where you're able to do absolute quantification without a reference curve, and hence it's made the process even quicker. More recently, NGS has been introduced. So the difference between PCR, in simple words, if you allow me to describe it. So NGS is a process whereby, again, you are looking at the same targets, an abnormality in the sequence of DNA, but you're able to do multiple sequencing simultaneously. So as a result, you're able to profile a very large chunk of DNA. And out of that, the difficulty is that when you're doing that, you may be able to find out a lot of like background noise. So you need to know what is that you're targeting and what is that you've targeted is relevant to that case with acute myeloid leukemia, where you could do MRD and use that as an effective MRD tool. And I'll show you the slides to explain what I've just said in a minute. The advantage of this technique is that it is a very highly sensitive method. It is easy to standardize, and you're able to look at much deeper level into the clone of acute leukemia with the help of this technique. However, that is also a disadvantage because what I've just said, that you may be able to identify a number of abnormalities which may or may not be relevant. Which ones are more relevant, I will show you in subsequent slides in a minute. One of the biggest disadvantage, again, for a developing country like Pakistan will be the development of these technologies, but I am aware of centers in Pakistan where NGS is available. So again, the human resources are developing in a country like Pakistan, and hopefully it will only go onwards and upwards. Again, the problem is that you are not able to identify a target in every single case. So there are pros and cons of every single technique that I've described to you. So in this slide, I've just summarized the depth of response that you can assess and evaluate in a patient where you are trying to identify the target and you are trying to look for the minimal residual disease. So as you can see from morphology, which you're able to identify 1 in 10 cells, to cytogenetics 1 in 20, you go down to a level of 1 cancer cell in a million cell population with the help of PCR, and you could go even deeper with NGS. However, I must highlight that NGS is not as straightforward. It depends upon your technique and equipment, and the sensitivity may vary from 1 in a million or deeper to much less sensitivity. So it depends upon your technical expertise and the methodology that you're using. So when should we do MRD assessment? I think it will be fair to say that MRD assessment in any developed center across the globe is now a standard of care, and not only in ALL, but also in acute myeloid leukemia. And ELN Working Party has come up with the suggestions when you should be doing MRD assessment. Again, MRD assessment will depend upon what kind of resources you have, what country you're working in, what are your clinical practices, and whether or not you are actually part of a clinical trial where you may be doing it more frequently or less frequently. So a basic question, why do we need MRD? It makes perfect sense for us to know the depth of response. because we know that the deeper the response, the more likely it is that the patient will achieve a long-term sustained remission. If the response is not deep enough, there are leukemic clones which are there to come back and give you what is called relapse of disease. Also, if we have a longitudinal data on MRD, then we may be able to pick up some trends. So how does it translate into clinical world? So I will start with a one of the very first prospective studies which was performed looking at the prognostic impact of MRD monitoring. So not surprisingly, it came from a pediatric trial, AML-02, where 216 patients were evaluated over a period of time. And as you can see, that the MRD cutoff was put at 0.1%. And based on that criteria, if you are MRD negative, then your relapse risk, as you can see in the figure, is lower. And if the MRD is higher, you are more likely to relapse. And as you can see, if you go up to induction 2 and you've still not achieved an MRD positive disease, then you're more likely to relapse. They not only looked at MRD positive and negative data, but they also stratified the patients into MRD true negative and those who had MRD between 0.1 and 1 and those who had more than 1. So what the right side of these figures show is that if you have a higher disease burden, and we're talking about patients who have achieved morphological remission, but if you have achieved higher disease burden, then you're more likely to relapse. However, this trial also indicated a dilemma which even today we face, and that is that when they escalated chemotherapy to high-dose cytarabine, unfortunately, the MRD negativity, they were not able to achieve in significantly more patients. So in other words, you know that there's a problem, you know that the patient is likely to relapse, but there's very little that you can do about it. One of the first prospective studies in adult came from this Haem-Onc group, which in collaboration with Swiss group published this data in 2013. So they were again looking at multi-parametric flow cytometry, and they were using A-color flow cytometry in AML-42A clinical trial. And as you can see, their cutoff was very similar to the initial pediatric trials and the data that you can see that in induction 1, 2, and after consolidation, if you have not achieved MRD negativity up until the time of consolidation, your risk of relapse is very, very high. So this data is replicated from what the pediatrician showed. But what was interesting in this clinical trial was that when they coupled MRD with an additional biological prognostic score of prognostic category of acute myeloid leukemia, what they found was that it increases the sensitivity. In other words, if you have a poor risk acute myeloid leukemia and you are MRD positive at the end of your consolidation, you are in trouble. The reason being that within 1 year, every single one of these cases, as you can see in the high risk curve, would have relapsed. So that means that MRD can be used in association with other parameters of disease. Now, this is more recent data which has been published from MD Anderson in 2017. And this is quite an interesting and important data. So again, they were looking at MRD in this clinical trial. It was 8-color multiparametric flow cytometry, but they used this clinical trial in the patient population was younger. They looked at the response at induction and consolidation and end of treatment. What's very important to remember, because it was a younger population, and you'll be surprised to see that the definition of younger population in America was 65 years, which I don't think holds true in developing countries where we might not class them as inverted commas younger, but they were able to give them very high dose chemotherapy like Flagida or clofarabine based chemotherapies. And as you can see, not surprisingly, that the patient at the end of induction, consolidation, and end treatment, if you are MRD positive, your survival is likely to be very, very poor. However, I would like to point out a very important matter here. So in this study, at the end of first induction, whilst they used very intensive chemotherapy, 79% of the patients achieved MRD negative disease. So they went on to give consolidation, and those who achieved MRD negative disease increased to 86%. But when they continued, they went up to 6 cycles of attenuated chemotherapy. Unfortunately, at that point, they were not able to improve MRD status. So that again points out the dilemma, which has been pointed out in the previous publications, that you know that there is a problem, you know that there is disease there, but what is that you can do about it? And that is a difficult question to answer. So so far I've talked about the clinical data on MRD using multiparametric flow cytometry. So does this data hold when you use molecular MRD? So one of the biggest data has been published by UK MRC group. It was the patients who were treated in AML-17 trial, and the example that I've given you was of a patient who was in AML-17 trial. So there were 346 patients who had NPM positive disease. And as you can see, not surprisingly, the patients who were MRD positive had a poor survival caused by increased incidence of relapse. Now, this is a very, very specific kind of description, because what they found was that the most relevant, most important prognostic marker was the persistence of MRD at the end of 2nd cycle of induction chemotherapy in the peripheral blood. So it's a very, very specific description of MRD at a certain time point, which determines the outcome. But what I would also like to point out is that they also did subgroup analysis. So if you have NPM, you could still have, for example, FLT3, which we know carries poor risk. Now, what's very, very interesting, and I would like you to focus on the last square, which is labeled as D. So what you can see is that if you have MRD positive disease and you are FLT3 positive, then you're likely to do bad. But at the end of 2nd cycle of induction chemotherapy, if you become MRD negative, and I'm talking about MRD using NPM here, then you carry almost the same outcome which a patient who is not FLT3 mutated will carry. This is a very, very important piece of information, which means that the FLT3 ITD becomes less relevant if you're able to achieve MRD negativity in this group of patients. Now, moving on, some more data from, again, MRC UK AML-15 trial in a different disease, which is core binding factor leukemia. What my colleague, Professor Yin, tried to do here was to categorize the burden of MRD based on molecular studies, PCR-based study. And what it showed was that even in those good risk leukemias, so-called good risk leukemias, if you have a high burden of MRD, then you're likely to do badly, as you can see in this figure. So we've talked about multiparametric flow cytometry. We've talked about PCR-based MRD. What about NGS, next generation sequencing, which gives us a lot of information? So this is an important paper which was published a couple of years ago from Rotterdam. What you can see here is that the patients who were found to have MRD, which you have figured out with the help of next generation sequencing, which is a very broad array of mutation abnormalities that you're able to identify. The trouble with that is that a lot of patients, after they've achieved morphological remission, were still persistently positive. And not only they were persistently positive, as you can see in the lower half of this slide, that they were persistently positive with a fairly high burden of variant allele frequencies. Now, let's see whether we can tease it out and see what is relevant information in this study. So not surprisingly, what they found was that in non-DTA, and I'll come to DTA in a second, non-DTA mutations, in other words, when you're doing MRD in acute myeloid leukemia, non-DTA mutation, if there's a persistence of MRD at the end of the chemotherapy, induction chemotherapy, you're more likely to relapse. That's more accurate term. However, what they also showed, and I think that's very important, that in those patients, if you subclassify the abnormalities that you're finding with NGS and separate out DTA mutation, which is DNMT3A, TET, and ASXL1 mutations, those mutations, persistence of those mutations after chemotherapy was irrelevant. In other words, not only the persistence of that MRD did not change the relapse incidence, but also at various levels of disease burden, moving from variant allele frequency of 30% to 1%, none of those carried any prognostic significance. In other words, what I'm saying here is that there can be some abnormalities within the NGS which could be completely irrelevant and they have no prognostic significance. Within the same study, they were not only doing NGS, but they were comparing also other forms of MRD evaluation, and they used multiparametric flow cytometry. And this is beautiful data which shows that if you couple together more than one different techniques for MRD assessment, you're able to then further categorize patients based on their relapse risk. So if you're NGS negative and you're multiparametric flow cytometry negative, you have the best outcome. Whereas if you are NGS positive and multiparametric flow cytometry positive, you're very highly likely to relapse. You know, the relapse risk in that group is about 75%, which is very, very high. So in this slide, what I've done is to summarize various molecular targets. And I'm not talking about those targets which are well established. And I've deliberately left off other targets such as PML-RARA, such as core binding factor and NPM, because I think it will be fair to say that we know a lot about those and they're well-established markers. However, what I'm focusing on this slide is those markers where there is a weakness. So as I pointed out that the DTA mutations are not as good, or in fact, they don't carry any prognostic significance because they do exist in pre-leukemic clones. In other words, you have eradicated the leukemic clone, but those can still exist. Likewise, if some of those abnormalities that you pick up on NGS sequencing are, for example, RUNX1, which could be germline mutation, then even when you cure the disease, you will still have very high level of variant allele frequency. So you can't really use that as a surrogate marker for a disease burden. There are other mutations, the other abnormalities, which are like overexpressed genes like WT1. So you need a very high level of kind of cover for that, and those are the abnormalities where the ELN MRD working party suggests that you should not use it as a single marker, and you should use alternative marker because the sensitivity and specificity of WT1 is very low when you're using it as an MRD marker. Other markers, we're all familiar with FLT3 ITD, for example, IDH, and so on and so forth. The problem with these markers, you must try and couple those markers with an additional means of MRD monitoring. It could be multiparametric flow cytometry, or it could be, for example, if the patient is FLT3 and NPM positive simultaneously, you should use more than one marker. This is a very quick slide, which I'll go through very quickly. This is just to show that the kinetics of relapse when you're doing MRD monitoring can vary depending upon what kind of marker you're using. However, what I would like to point out is that one very important feature of monitoring MRD is how bad the MRD is going. If MRD is increasing, that is a bad sign regardless of what kind of underlying abnormality you're monitoring, and we're talking about molecular MRD. So these are data from the patient that I just spoke to you about. So the patient achieved complete morphological response after first induction and achieved MRD negative disease, so we're quite chuffed about it. However, unfortunately, we continue to monitor it, and unfortunately, the patient developed MRD positivity at the way and came back with morphological relapse. And on the left-hand side, you can see raw data from AML. Now, we know that there is a problem. We know that we can identify that, but is there anything that we can do about it? So this is data from Seattle, basically. What they did was to look at the deep ablative transplant, and what they found was that in risk of relapse and as for survival, the patients who have MRD positivity, they did as badly after the transplant as those patients who had active disease. So that's very important piece of information. However, we went a step further, and this is data. These are data from CIBMTR, and these patients were treated within BMT CTN 0901 clinical trial. And what they did was to go back and look at their sample and retrospectively did a deep sequencing. Again, they used NGS here to try and see whether there were any patterns within the reduced intensity conditioning transplant and myeloablative conditioning transplant which could alter the outcome of patient. And I think this is very, very important data. What basically it shows, if you look at this this figure, is that if you have MRD negative disease, then you're likely to do okay before the transplant, so you'll do okay after the transplant. However, and that is regardless of the intensity of conditioning that you will use. However, if you are using reduced intensity conditioning transplant and you have MRD positivity, then your outcome is significantly poor. In other words, MRD positive disease, myeloablative transplant, you're able to overcome that adverse feature. However, reduced intensity conditioning T1 is just to show you that if you don't have any other MRD marker, you could still use WT1, where ELN has, working party has put some caution against the use of it. But as you can see very clearly that if you have published from AML MR, the patients who were treated in AML-17 trial. In a way, this is a follow-up data from what was published by Evie et al. In 2017 in AML-17 patients who were NPM positive. So in these data, they've shown 861 patients who were NPM positive. And again, they've essentially replicated what they showed previously in those patients who were treated for acute myeloid leukemia. And these data relate to the patients who ended up having allogeneic stem cell transplant. As you can see that in figure A, that those patients who are MRD positive did badly in terms of overall survival due to the increased risk of relapse. But the most sensitive parameter, as they indicated previously, was the persistence of peripheral blood MRD after second cycle of induction chemotherapy, where there was which was the most sensitive marker. What they also tried to do was to further risk stratify subgroups of patients, and what they found was that the higher burden of MRD, as defined by the parameter on the left-hand side of the slide, you are very likely to relapse. Whereas if you achieve MRD negativity, you are you will do well. And those in the middle did something in between. What I would like to point out here, and I think this again is a very important data, which again confirms what they saw previously, was that if you have high incidence of MRD, and if you do subgroup analysis of those patients who are NPM positive and whether or not they have FLT3 ITD mutation as well, so if you have MRD positive disease, then regardless of your FLT3 status, you will do badly, which makes sense. And as you can see, the outcome is really, really bleak. What they showed also was that if you have low level of MRD, as I described earlier in the previous slide, the FLT3 status becomes more relevant. So if you have low level MRD, your FLT3 positivity leads to a poorer outcome. However, in my view, this figure number 3 is even more important, because what it shows is that even though we recognize FLT3 as a bad prognostic marker, but at the end of second cycle of induction, you've achieved peripheral blood negativity, then even if you relapse, your outcome is likely to be okay. Now, that means that you're able to abrogate that FLT3 prognostic significance in this group of patients, depending upon how they responded initially. And if you look at this paper, those patients who were treated initially, who were NPM positive and FLT3 positive, who went on to have disease relapse, their survivals with the salvage treatment and subsequent chemotherapy and bone marrow transplantation was 88%. So that means that you can refine your thinking process based on the MRD assessment. Now, based on what they've demonstrated in this paper, they've categorized patients into 2 groups. One was those patients who were categorized as low risk. The low risk patients were regardless of FLT3 status, and that's very important. Those who achieved MRD negativity. High risk patients were those who had high level of MRD positivity. But intermediate risk group, they classified them into either low risk if they had FLT3 negativity, or high risk if they're FLT3 positive. And as you can see, those patients who are in low risk, and may I point out that these are also those patients who had FLT3 ITD positive as well had a really good outcome. So in other words, that the MRD negativity in that group of patients abrogates some of the adverse features that you see with FLT3. So to summarize, what I would say is that there is no single MRD technique which is perfect. All techniques have their pros and cons. MRD should be done as a standard of care if your resources allow at specific time point, but I pointed that out earlier, that it depends on your clinical practice, your resources, and so on and so forth. And I think what's very important is that, and I think that will be the future, that different techniques should be used in conjunction because they increase the sensitivity of what you're trying to assess here. MRD, without a doubt, is a very valuable prognostic marker which predicts relapse and outcome of patients. And it can help us refine management, but I've put 3 question marks there because we know that we need to refine management, but how do we do it? It's still an area for exploration. MRD should be managed before transplant because we know that before transplant, if you are MRD negative, you're likely to do better. But as I've shown you in the data, even if you keep giving further cycles, it is not guaranteed that you will achieve MRD negative disease before the transplant. So how far did you go? What kind of strategies that you use? Again, we don't know. Can the conditioning be selected based on MRD? Again, there is data from MD Anderson, which suggests that yes, it can help. What I would say is that we are in dire need for prospective studies to try and further kind of answer these questions. Thank you very much.
Thank you very much, Dr. Saif, for such an informative talk. You have 2 very pertinent questions. Two from Dr. Hussain, that is from Shaukat Khanum Hospital. She's also a transplant physician. She asked that, she's typed it and I'm reading it out. Do you do MRD at your center after first induction or after second induction? And her second question is, do you change your management plan, chemotherapy for AML after MRD?
Okay, thank you, Bushra. I hope you're doing well. So in the center that I'm currently working, we have limited facility to do MRD. However, in the United Kingdom, where I was working until very recently, we were routinely doing as a standard of care, we were doing MRD. And yes, we would do MRD at the end of first cycle and second cycle. And also remember, it depends upon whether or not you have a relevant pertinent MRD marker. For example, if you have NPM, you would definitely focus on the most relevant time point in the MRD monitoring cycle. So that is induction cycle, peripheral blood. So we will do peripheral blood and paired peripheral blood and bone marrow MRD. Whether or not we will change our practice if MRD was persistent, I think that is a question that we don't know the answer to. However, at the end of cycle, at the end of treatment, if a patient has achieved MRD negative disease and subsequently the patient is found to have MRD positivity, or if the patient is continuing to show persistence of MRD, yes, then as we see a rise in MRD, we would want to give them salvage chemotherapy and take them to the high risk arm. And that is, I'm talking about the practice in the United Kingdom, but obviously the practice here where I work currently, where we are trying to establish, in fact, the MRD. We have a wonderful colleague who has actually come from the United Kingdom a few years ago, who is trying to establish that.
Another question from Dr. Shehzad Nasir Raja is, what are your comments about maintenance chemotherapy in AML?
I think there is very little evidence apart from APML, as you know, that maintenance therapy can help. I know that there are some studies where we are looking at, because remember the problem with maintenance therapy is that it will also carry significant toxicity. But as in this day and age, we are developing those agents which are fairly safe, such as oral azacitidine, which I have personal experience of using. I think the trials are going on at present, and I think maybe in a few years' time we will have the answer to your question, but it's a very good question. I think there may be a role. Personally, that's what I feel, but we don't have the data yet.
Giri Kamar, Commandant Armed Forces Bone Marrow Transplant Center, I would like to ask a question. Your experience about one cycle of anthracycline-based chemotherapy versus 2 cycles, as far as your experience of MRD is concerned, the impact of 1 cycle of anthracycline followed by consolidation or 2 cycles of anthracycline.
Okay, so in my current experience, we've been using MRD as if in molecular MRD, which would be NPM. So as you know, that the most relevant time point in that MRD is a 2nd cycle of chemotherapy. So we would not necessarily change our induction strategy. So if you have given, as a routine practice, we'll give daunorubicin and cytarabine, so anthracycline. But then regardless of MRD status, we'll move on to give a 2nd cycle of same chemotherapy. That would be the routine MRC practice. However, at that point, if MRD is positive, then you may want to kind of alter your strategy for future. So to answer your question, we would give generally 2 cycles of chemotherapy. Now, if the patient did not achieve morphological remission, then you will flip them to high-risk arm, and then you will go with something more intensive like high-dose cytarabine.
Thank you very much, Dr. Saif. With this, we come to the last presentation of today's webinar, last but not the least. And for that, I would request my own colleague, a very seasoned, very senior transplant physician and working at Armed Forces Bone Marrow Transplant Center, Brigadier Syed Kamran Mahmood. He's going to make us wiser about management options for AML in 2020. Over to Sir Kamran. Thank you very much, sir.
Bismillahirrahmanirrahim. Thank you, PSH, for inviting me to deliver this talk at this August forum. I was assigned topic of management of acute myeloid leukemia in 2020, which I have changed to treatment of acute myeloid leukemia in 2020. These are my disclosures. I've changed it to treatment because it's such a vast topic. Managing acute myeloid leukemia is a big topic. It includes many things, from diagnosis to follow-up and everything, but I'm going to restrict myself because I know there's a very little time left for me. So just for the treatment aspect of AML, and I have not included acute promyelocytic leukemia, and I would, of course, we have certain limitation to the availability of drugs in Pakistan, so I'm not going to go into details of the drugs which are not yet available here. This is going to be the sequence of my treatment, introduction, followed by some general recommendations, and then inductions and how to assess response, and then consolidation. And then, of course, about some old and unfit patients, because majority of AML patients are older age group. And then some difficult to treat AML, like therapy of treatment-related AML and relapse and refractory diseases, of course, then supportive care, which is so essential for AML. And then finally, about the novel drugs and what we have in market and what we have in pipeline. So AML is among the most difficult cancers to treat, and there are more clinical trials than many more common malignancies, but the results have been largely unsuccessful. And there is unacceptable 20% treatment-related mortality. This is more than any other malignancy, if you count all these solid organ tumors. And the cure is only for a minority of favorable risk subtypes. But despite most patients achieving morphological remission with intensive chemotherapy, the prognosis for long-term AML remains poor. And majority of these patients, the median age of AML diagnosis is more than 60 years. So majority of these patients are older adults, and it is particularly difficult to treat them. And the 5-year overall survival is dismal, 27.2%. The treatment option comprise a variety of chemotherapy and biological agents and stem cell transplantation. And for the past 45 years, nothing has much changed. And still, the anthracycline plus cytarabine has been the standard of care. Although since 2017, several new targeted therapies have been rolled out in quick succession, but most of these are beneficial in specific situation, which we will discuss. So all the guidelines tell us that whenever you diagnose a patient, the first thing is that you enter them into a clinical trial. But as you know, there are no clinical trials available in Pakistan. So the next thing is to offer them standard therapy if they're fit enough to withstand that therapy. And as I've said, it's one of the most difficult cancers to treat. And so admission is a mandatory. You cannot treat an AML in outdoor if your intent is to cure that person. And these patients require frequent readmissions for consolidation and for management of toxic effects of chemotherapy. So what we tell the patients now, we can call it a COVID-19 strategy, that to keep social distance, wear masks, have food discipline, and if they develop fever, that should be immediately treated with intravenous antibiotics. Transfusion support, of course, is a must. We must be aware that although it's not as common in ALL, CNS disease do occur, and if patient has got sign and symptoms of CNS involvement at the diagnosis, then relevant imaging studies should be carried out and lumbar puncture should be done. But in patients who do not have any symptoms, but the lumbar puncture should still be considered at the end of induction. Those who have monocytic differentiation, mixed phenotypic leukemia, or high WBC count, and extramedullary disease, or are positive for FLT3 mutation. Radiotherapy has got very limited role for extramedullary disease and after the chemotherapy usually. So patients are best treated at a center who is very, very tricky to treat in AML. So most initial treatment decisions of AML are based on two things. One is the age of the patient. Second is the performance status of the patient. And the history of whether the AML is de novo or it has evolved from prior MDS or cytotoxic therapy. So these three things are going to decide what type of induction therapy you are going to give to your patient. The intent of traditional induction chemotherapy is to produce major reduction in leukemic burden, and the more important is to restore normal hematopoiesis. So as Dr. Saif has said, the younger is defined in the West as anybody who's less than 60 years of age. But what is more important is not that we have seen that for young fit patient, the 3+7 is still the order of the day. And for that, the patient must have an adequate cardiac, hepatic, and renal function. And with induction of 3+7, you can expect 50 to 65% of patient achieving CR with 1 or 2 courses of induction. So this pretty much remains same as it was for many years, that you give induction with anthracycline plus cytarabine, and we'll come back to this slide later on and see what has been added to this now in recent past. So at the end of the induction, you assess the response, and response is categorized as complete response. It may be morphologic, cytogenic, or molecular. You can have a complete response with incomplete count recovery. And at the end of first induction, if the patient has partial remission, you may give a second induction. And at the end of second induction, you then label the patient whether the patient is in remission or has induction failure. So I will not talk much about MRD. You have had your full dose on MRD, but this is what, when we do MRD assessments, first is done upon completion of induction, that is before starting consolidation. If you have given one induction, then you assess MRD at the end of first induction, and if you have given two induction, then you assess MRD at the end of second induction, because this is important, that if you have MRD at the end of induction, then this is the patient who is a candidate for transplant. And then you assess the MRD before you take the patient to transplant, because this is the patient, as Dr. Saif has said, that they are not going to do very well even with the transplant. So here is the answer to the question of Dr. Shazad, that some of these patients do require some sort of a targeted maintenance after transplant if they were MRD positive. So it is important to do MRD before proceeding to transplantation. So consolidation options are whether you can continue with the chemotherapy, or you can offer autologous or allogeneic transplant to your patient. For young fit patient, they must always be evaluated for allogeneic transplant, except for those who have got favorable cytogenetic and molecular markers who may be expected to be cured solely by chemotherapy. And of course, the patients who are unfit to tolerate transplant, they can be offered some sort of chemotherapy. In low-risk patient, non-transplant approach could be considered, and for this, the standard of consolidation is the high-dose RSE. The dose and the cycles have not yet been established. It's been given from 1.5 to 3 gram per meter square on 3 days and 6 doses. And some people are giving 2 cycles of consolidation after 2 inductions, and some are giving 4 cycles. But good risk AML may expect to be cured with the 4 cycles of high-dose RSE consolidation. For patients less than 60 years of age, NCCN recommend matched sibling or alternate donor transplant in following situation. One is if there is induction failure, this patient may be worked up for transplant, and with significant residual disease, as these patients are not going to be cured otherwise. And even those who achieve complete remission, the post-remission therapy should as a transplant should be offered to intermediate and poor risk categories of patients. And patient with MDS related changes and treatment related disease, they should also be offered transplant, as they are not usually cured by the chemotherapy alone. The problem with the older patient is that you can't really treat them very aggressively, so their treatment remains unsatisfactory. And only 9% of patients were alive after 4 years in one study, and that was considered to be overestimation, because only 30% of the elderly patients, they actually received chemotherapy. So majority of those patients, they never receive any chemotherapy, and the median survival was just 6 months with chemotherapy, and without chemotherapy it was less than 1.7 months, and most of the time they were in hospital. So the factors associated with an adverse outcome include age greater than 75 years, and that is for the West. I don't know what's the age for us, maybe 55 or 65. Poor performance status, previous antecedent hematological malignancy, unfavorable karyotype, renal insufficiency, and treatment outside of a laminar flow room. This is important. We must try to get this facility in most of the places where we are treating these AML patients. And as you see, if anyone having more than 3 or more risk factors, then the 2-year survival is just 3%. So there is no standard consolidation therapy for older patients, and they should be offered a clinical trial or maybe treated according to the institutional policy. And you can offer them any modified sort of a low dose chemotherapy, including RSE and including low dose 2+5. And these patients, if they are fit, can be offered autologous transplant or maybe a reduced intensity and non-myeloablative transplant. Hypomethylating agents are the most commonly prescribed drugs for elderly with AML. The response rates are low, but they are well tolerated and they prolong remission in some of the patients. And they are active in patients with complex cytogenetics and TP53 mutation. This is now a very, very popular drug, venetoclax, in elderly and fit patients. It's a selective inhibitor of BCL2, and it is usually used in combination with methylating agent and low-dose cytarabine and achieves a reasonable response. Hematopoietic stem cell transplant is very, very difficult in elderly, but as I have said, if they are fit, they may be offered reduced intensity conditioning transplant. Therapy-related AML has got a poor prognosis, median survival less than 6 months. Transplant has generally been recommended for these patients who are fit enough to undergo transplant. And this is one drug which has been particularly approved for therapy-related AML, and it is the liposomal combination of cytarabine and daunorubicin, the CPX351. And its role appears to be in patients with history of MDS who were never treated with hypomethylating agent. And it has got same toxicity as standard 3+7. So anybody who's unfit for 3+7 is also unfit for CPX351. Therapy of relapsed AML is equally dismal, extremely poor. Young patients who have not previously undergone transplantation should be referred for such therapy. And chances of obtaining a second remission with chemotherapy correlate strongly with the duration of first remission. So if the duration of first remission is more than 2 years, then the chances that the patient would respond to the salvage therapy is around 73%. But if somebody has relapsed less than a year, then the CR rates are not more than 14%. And if somebody who has got no response with first salvage therapy, then there is no point in giving any further therapy because a second salvage therapy response rate is 0. So for patients who are able to tolerate aggressive therapy, there are a number of options that are quite toxic, and we usually use FLAG-IDA in such situations, but these are the protocols which have been used for in these situations. For patients who are not fit to undergo such toxic chemotherapy, you can use hypomethylating agent and venetoclax in combination with low-dose RC. This is what we do usually in our elderly patients. Supportive care is important. I would not elaborate on the supportive care, but you need to have adequate blood component support, and must have an institutional policy on how to treat infections and how to treat hyperuricemia and growth, how to use growth factors. Now, I would deliberate upon some of the newer drugs which have come up in past 3-4 years. So novel arsenal of diverse therapies, sometimes in combination with previously used chemotherapy, have drastically altered the landscape of acute myeloid leukemia treatment and has promulgated new treatment paradigms. So this is the all too familiar wagon wheel. I have posted this slide just to give you an idea of the wide array of the molecular and cytogenetic landscape of acute myeloid leukemia. And So there are a number of abnormalities, number of targets against which treatments can be developed. And these are a number of sites of actions of chemotherapy and targeted therapy and epigenetic and metabolic therapy and immune therapy. And you can see the various drugs and the various sites where they act. Some of the newer drugs which are coming up, we'll discuss later on. And on the basis of this landscape of abnormalities in AML, they have defined the risk categories, and they have defined AML into favorable, intermediate, and adverse risk. And this is very, very important. And then they have come up with some very, very promising targeted therapies. And you can see from April 2017, when midostaurin was relaunched as a FLT3 inhibitor in combination with standard 7+3 induction. There has been a number of drugs, IDH inhibitors, and then the CPX351 and anti-CD3 and CD33 antibody gemtuzumab ozogamicin, and then we have hedgehog inhibitors and BCL2 inhibitors. So coming back to that slide that I showed you before, when we have only choice of 3+7, now we have added some more drugs to them. So we have some specific situation where we can benefit from these targeted therapies. So if the patient is CD33 positive, you can add gemtuzumab ozogamicin. And there are other drugs, anti-CD3. Then you have FLT3 inhibitors. You can add FLT3 to your standard 3+7. And in elderly patient, this CPX351 is there. And then venetoclax and IDH2 inhibitors are also now being used. So now we'll have a look at these drugs individually. So CPX351 is a liposomal formulation of daunorubicin and cytarabine, which release drug in fixed 5:1 molar ratio. It has shown a superior overall survival with an improved safety profile, except for prolonged myelosuppression. So it is quite toxic, but it has got better safety profile. FDA has approved for adult patients of any age with secondary AML plus those with MDS-related chromosomal abnormalities. So midostaurin is the only FLT3 inhibitor to date that has demonstrated an overall survival benefit in combination with induction chemotherapy. And in a phase 3 trial, induction chemotherapy plus minus sorafenib in older adult was ineffective and more toxic actually, but in younger adult, it has improved event-free survival, although overall survival was not much different. IDH2 and IDH1 inhibitor, IDH is a family of enzymes for cellular energy generation in oxidative decarboxylation cycle, catalyzing conversion of isocitrate to alpha-ketoglutarate. And 20% of AML patients carry this mutation, and mutant IDH has become a viable target in AML treatment. So beside these IDH1 and IDH2 inhibitors, ivosidenib and enasidenib, venetoclax also targets the IDH and is quite effective. So the response rates were very impressive, 93% and 73% with ivosidenib and enasidenib arm respectively. This glasdegib is a hedgehog inhibitor and is an oral agent. That's then a big advantage. And it has demonstrated growth inhibition of AML cell line. And it has been given approval by the FDA in combination with low-dose cytarabine for unfit older patients. It has now been, the trials are being conducted to see how it works in the younger fit patients. Venetoclax is the most promising of all the new agents. It's an oral small molecule of BCL2 inhibitor. And initially, it has demonstrated overall response of 19% as a single agent, but combined with other drugs, it has been very impressive, and it has also been active in ID8 mutations. Venetoclax, an hypomethylating agent in elderly unfit patient, achieve a CRI of 61%. And with low-dose cytarabine, it has shown a CRI of 35%. And for secondary AML, but for de novo AML, the response rates were as high as 71%. So these are the drugs which are now being used even in Pakistan. We have been using midostaurin and even IDH inhibitors and gemtuzumab and venetoclax. Now I will go through some of the drugs which are in pipeline, and the trials are going on, and there is a wide array of these drugs. So we have conventional chemotherapy, and then HEDOC inhibitors and FLT3 inhibitors and IDH inhibitors. But we also have now pro-apoptotic agents, BCL2, microenvironment targeting and cell cycle checkpoint inhibitors, epigenetic regulators, then immunotherapy in the form of antibody-based therapy, bispecific antibodies, and CAR T cell therapy is also coming up for AML, and then we have checkpoint inhibitors and a vaccine, very interestingly, for AML. So microenvironment targeting therapy is very interesting in that E-selectin is a cell adhesion molecule involved in migration of leukocytes along vascular endothelial cells, and is highly expressed on leukemic block. And this drug, uproleselan, is an antagonist of E-selectin, and it enhances the chemotherapy response and also ameliorate the chemotherapy toxicity in animal models, and has shown a moderate response rate of 41%. One of the mechanisms of chemotherapy resistance involves cell cycle regulators recognition of DNA damage, which delays mitosis to allow repair to be initiated. And these cell cycle checkpoint inhibitors have been developed to counter this, and a number of them coming up. Then we have epigenetic regulators, and they are useful in restoring the function of some mutations directly or indirectly, and has so these mutations, I don't know how useful they would be, but there is a lot of work going on in these epigenetic mutations, but they have not been shown to have promising results. Antibody-based therapy, you have already seen that anti-CD33 monoclonal antibody gemtuzumab is being used now regularly in combination with 3+7, and it has shown a significant advantage in overall survival. It is especially beneficial in cytogenetically favorable risk AML. Bispecific antibody utilize two different variable regions to provide contact between cells and create a T cell activation against tumor cells. So AMG 330 is a bispecific antibody against CD3 and CD33 that demonstrate AML cell cytotoxicity, particularly in favorable risk disease. CAR T cell have been difficult to develop in AML. AML bears heterogeneous cells that can offset killing by a single CAR-based therapy. So they have found out two targets so leukemic cells associated with CLL1 expression and CD33 expression in myeloid marker, and they have targeted both CLL1 and CD33 on AML cells. This has demonstrated the feasibility and safety to achieve complete response. Checkpoint inhibitors have not been very useful in AML. They have been PD-1 blockade agents, especially nivolumab and pembrolizumab have been used in lymphomas, but they have not been very useful in AML. Vaccine can trigger an immune response to tumor-associated antigens by peptide vaccination or through fusion with dendritic cells that present antigen. They have shown to have a disease-free survival of 16.9 months in otherwise refractory AML. So the relapse rate was 68%. So they are still in development. So to conclude that prognostic significance of cytogenetic and molecular abnormalities is almost all in context of intensive induction chemotherapy. So 3+7 remains. There is reason to believe that leukemia stem cell targeting therapy might not be impacted by traditional adverse risk disease factors. Venetoclax, the presence of long feared risk factor like complex karyotypes and mutations in FLT3 and TP53 do not appear to have a major impact on a patient's ability to respond to venetoclax-based regimen. And so venetoclax appear to be the game changer in AML, and the trials are going on in younger age group, and it has been combined upfront with 3+7 to see the effect in CR and CRI. And it is time to give chance to younger fit patients to benefit from targeted approach beyond 3+7. Thank you very much.
Thank you very much, sir. Thank you very much for throwing light upon a very difficult subject, that is management options for AML in 2020. Dr. Khalid Zafar Hashmi from Karachi, our teacher, our very experienced hematologist, has given a comment that D3A7 was developed by Cambridge Group 45 years ago. And he says that there is no much change about the treatment of AML even after 45 years. But sir, after presentation of Brigadier Kamran, you must be aware that there's lots of change, lots of drugs and vaccines and many more things for AML. So let's see how it goes. Thank you very much. I express my gratitude to all the panelists for sparing their precious time on Saturday morning and for very informative talk. I must say it was, all the presentations were wonderful. Over to General Pervez for his note of thanks. Thank you very much, everybody.
My special thanks to the speakers for sparing their time and preparing the talks. I'm sure these were very useful talks for all of us for a difficult area in hematology. And thanks to the participants for their sparing this time. And see you all on our next webinar that will be on 19th September, inshallah, on MPN. And I wish everybody a happy weekend. Thank you very much.
Thank you very much.
Thank you. Thank you very much.
Allah
Take
Hafiz.
care. Bye.